Hello friends, we have learned in detail about the anatomy of external layer and then we have started with the various disorders of external layer. In the last class we learned about the congenital and traumatic conditions of external layer. Today we will be learning about the inflammatory and neoplastic conditions of external layer along with certain other conditions that are seen in daily ENT practice. First of all, let's see what this condition is. If you look carefully in this picture, which may be asked as an image-based question, you can see that the whole of pinna is red and inflamed except for the area of the ear lobule. Okay, in the ear lobule, what is happening? It looks normal. Okay, rest of the pinna is red and inflamed. And what is the specialty of ear lobule when compared to the rest of the pinna? We have learned that there are only two areas in pinna where there are no cartilage seen. And what are they? One is the ear lobule, the other is the incisura terminalis. So it is very safe to pierce a near lobule but not in any other area of the pinna. So what happens if you are going to pierce your pinna like this all over the area of the cartilage? It can cause an infection. And what is this infection caused by? It is being caused by Pseudomonas aeruginosa, which is an obligate aerobe, and yes, this Pseudomonas aeruginosa results in perichondritis of pinna. Okay, it results in perichondritis of pinna, and so the condition that you see here is pinna perichondritis. Okay, now in pinna perichondritis, what is the treatment? How will you treat the patient? I already told you it is being caused by Pseudomonas and it is caused by trauma to pinna. It can be a trauma due to some road traffic accident or it could be a self-inflicted trauma due to piercing of the pinna. Okay, whatever be the reason, if the patient comes with pinna perichondritis, he needs admission and intravenous antibiotics which are directed against Pseudomonas. Okay, and what are the anti-pseudomonal antibiotics? You already know it is ciprofloxacin, which is very much effective against Pseudomonas, right? But it is usually given as oral antibiotics. Even IV antibiotics can be given, but when admitted, it is better to give a more effective antibiotic against the Pseudomonas. Why? Because when a patient is having a perichondritis of pinna, and if not treated properly in time, what happens is that the patient's pinna can get deformed and the shape of the pinna will be lost forever. Okay, so to prevent that, you have to admit the patient and start him on IV antibiotics that are against Pseudomonas. And what are these antibiotics that are commonly given? One is the injection which is effective against Pseudomonas, that is Fortum. Okay, injection ceftazidime is active against Pseudomonas. Then you can give injection gentamicin, amikacin. Okay, and of course injection piperacillin plus tazobactam. Okay, so all these antibiotics can be given. Sometimes what you will need to do is make a window in the pinna and then you have to remove the cartilage from that area if it is severely necrosed and it is causing problems. Then you will need, that is a drastic measure which is taken when the perichondritis is not improving in spite of IV antibiotics. Okay, so that's about perichondritis of pinna. Now there is another condition which is being caused by the same Pseudomonas aeruginosa, and it is seen in people who take a swim like this, or it is seen in swimmers, and that's why it is also known as swimmer's ear. Okay, why it is seen more in swimmers? Because when water enters into air, the nature of the pinna, the nature of the external canal changes. Okay, the external canal is generally acidic in nature, and when water enters, it becomes more of alkaline, and it favors the growth of Pseudomonas aeruginosa, especially when there is a trauma in the external canal. And it is seen in areas which are hot and humid like Singapore, and hence it is known as Singapore ear also. Singapore ear. And yes, it is seen in people who use more of telephones. Okay, and that is why it is known as telephone ear. And yes, just like I showed you in the last class the self-inflicted trauma due to using a feather or even earbuds when used indiscriminately in the external aortic canal, it can result in trauma, and any trauma in the external aortic canal can cause severe inflammation, and because of the edema, the stretching of the nerve fibers within. And what is the nerve supply of external aortic canal? Yes, that is something which we learned. What is that? It is auriculotemporal nerve and auricular branch of vagus nerve, isn't it? And through these nerves, the external aortic canal pain is being conveyed to body, and the pain can be very severe. Okay, you might think that the patient is having some big problem because of the severe pain of the patient, because actually the pain is severe because of the edema within. Okay, the external aortic canal, if you look, you can see that it is severely edematous, and yes, the patient will complain of severe earache, and the pain will be worse on chewing as well as talking. Why? Because the temporomandibular joint is seen very much nearer to the external aortic canal. It is seen anterior to the external aortic canal, and because of that, the pain from the external aortic canal is getting into the temporomandibular joint. Okay, and because of the movement of the external aortic canal, the when the temporomandibular joint moves, the pain will be increased. Okay, and that is about the otitis externa part. And this type of otitis externa, which is seen in the whole of external aortic canal, is what is known as diffuse otitis externa. Okay, so we were talking about swimmer's ear or telephone ear or Singapore ear, and that is another name for diffuse otitis externa. Now, what is the telltale sign of otitis externa? How will you diagnose otitis externa? It is by the sign known as tragal sign. Okay, if you are going to press the tragus of the patient like this, the patient will wince in pain. Okay, that is what is known as tragal sign. You have to be very careful and gentle while examining a patient who is suspected of having otitis externa. Okay, and when you are going to examine the ear canal, usually in medical colleges especially, we use a headlamp like this, a head mirror like this. Okay, and a bullseye lamp is used for focusing. Okay, and what is this head mirror? It is a concave mirror, and it is having an outer diameter of 9 cm and inner diameter of 2 cm with a focal length of 25 cm. And from the bullseye lamp, which is a 200-watt lamp, the lamp light gets reflected with this head mirror, and it is focused onto the ear. And to see the tympanic membrane properly, what have I said that you must do? You have to pull the pinna upwards and outward, isn't it? And if you're going to pull the pinna upward and outward for a better view to see if there is an involvement of tympanic membrane, what will happen if the patient is having otitis externa? The patient is going to slap you, because it is very painful if you are going to touch the pinna in a patient with external aortic canal. Because when you are pulling the pinna, what happens? There is an movement of the underlying perichondrium of the external aortic canal, because the whole of the pinna cartilage is getting continuous with the cartilaginous part of the external aortic canal, and because of the movement of the pinna, the cartilaginous is also moving, and because of that there will be severe pain, and the patient will have severe pain because of that. So never do it. Okay, when a patient is having an otitis externa, and if you are able to diagnose it with the tragal sign, never go for it. And whenever you use a otoscope for examining such a patient with an ear speculum, you have to use the smallest ear speculum. Okay, the smallest ear speculum has to be used for that. Why? Because in such a patient there will be severe pain when you are trying to insert the ear speculum. Okay, so that's about the diffuse otitis externa. The diffuse otitis externa is also known as swimmer's or Singapore or telephone ear. Okay, this can be asked as a one-liner for you. Okay, and it is caused by Pseudomonas aeruginosa. And there will be pain on talking and eating. because of the movement of temporomandibular joint causing movement in the area of the external aortic canal. And on examination we will be able to see that the external aortic canal is edematous like this. Okay, it is having severe edema, and also you can see purulent ear discharge. Okay, purulent ear discharge. So when you see that the patient is having purulent ear discharge in the external aortic canal, what will you have to do? You will have to remove it, isn't it? And what is that known as? It is known as ear toileting. Okay, ear toileting has to be done for the removal of the discharge from the external aortic canal. Okay, and yes, the patient will be having severe pain on ear movements, and when the patient comes to view with such pain, and the patient is having a otitis externa, I told you it is a condition which is caused by Pseudomonas aeruginosa. So how will you treat the patient? You will have to give him antibiotics, and the antibiotics has to be directed against Pseudomonas aeruginosa. Okay, and do you have to admit the patient? No, for diffuse otitis externa it is not needed. Actually, the mainstay of treatment of diffuse otitis externa is more of local antibiotics than systemic antibiotics. Okay, because it is the edema of the external aortic canal that is causing the severe pain. Okay, so how is the local antibiotics given? It is given in the form of an ear wick. Okay, ear wick which has got antibiotic plus steroid ointment, and also you can give istamamol glycerin. Why? Because it reduces the edema. Okay, for reducing the edema. And along with that you can give oral antibiotics in the form of, yes, of course you can give ciprofloxacin. For 5 to 7 days it can be given 500 mg BD. Okay, so that's about diffuse otitis externa. Now if an old man comes to you with otitis externa, and yes, he is having severe pain and it is worse at night. Okay, if it is worse at night, and in that case when you are examining the ear canal, you not just see the ear discharge but also see granulation tissue. What do you see here? This is granulation tissue in the hand, isn't it? But in the ear canal it appears like this. It is seen in the floor of the external aortic canal like this. If there is granulation tissue like this, and on culture of the ear discharge that you got, if it shows as Pseudomonas aeruginosa, then you have to suspect a condition which is known as malignant otitis externa. And this malignant otitis externa is a condition that is not a malignancy. Okay, you might think it is a malignancy from the word, but it can be as severe as a malignancy, because it can cause all the problems a malignancy causes, such as multiple cranial nerve palsy. Okay, the area of the external aortic canal, if it is invaded by a malignant tissue, what can happen? It can cause cranial nerve palsy. In a similar manner, it can cause multiple cranial nerve palsy, and apart from that the patient can have severe pain. Why? Because it is actually causing skull base osteomyelitis. Okay, skull base osteomyelitis. And unlike the osteomyelitis that we have learned in ortho, where the most common organism is Staphylococcus aureus, this skull base osteomyelitis is being caused by Pseudomonas aeruginosa. Okay, Pseudomonas aeruginosa causes skull base osteomyelitis, and there is a criteria for this Pseudomonas aeruginosa, for this malignant otitis externa. Now what is the criteria known as? It is called Levinson criteria. Okay, Levinson criteria. Why did I keep this picture? Because you can see 11 here, isn't it? And 11 is kind of like his son. Okay, you can see that she has put a boy cut and she's being treated like his own son. So that's why I put this picture so that you remember the name. Okay, now what is this Levinson's criteria? Levinson's criteria is the criteria which is used for diagnosis of malignant otitis externa, and it includes refractory otitis externa. Okay, so whatever you are doing, the otitis externa is not getting subsided. That is one thing. And there is severe nocturnal otalgia. And on examination you can see that there is purulent ear discharge, and on culture of this ear discharge you will see that it is due to Pseudomonas aeruginosa. And in the ear canal you will be able to see granulation tissue, and of course it is seen in immunocompromised patients, and most commonly it is seen in people who are having diabetes mellitus. Okay, diabetes mellitus. So in an old man, it is seen in old people, and usually they have some immunocompromised conditions such as diabetes mellitus, malignancy, or anything like that. Okay, so if a patient who is having diabetes mellitus comes to you with severe otitis externa which is not subsiding, and there is severe nocturnal otalgia, okay, in that case the patient will have purulent ear discharge, and on examination if you see granulation tissue, then you have to suspect Pseudomonas aeruginosa. Now what is the importance of detecting this condition early? Because this condition requires intensive treatment, because this is a condition where the otitis externa is not restricted to the external canal. It has spread into the skull base. Okay, we already know that the external canal is seen as a canal within the skull base, and it is having the floor and the roof formed by the skull base. Okay, so what you have to do is the patient has to be admitted, and the patient has to be given intensive intravenous antibiotics for 4 to 6 weeks until the skull base osteomyelitis subside. Okay, if the skull base osteomyelitis does not subside, what happens? It can result in motor neuron palsy of the facial nerve. Okay, or facial nerve is the most common nerve involved, or it can even result in 9, 10, 11, 12 cranial nerves. What happens when 9, 12 cranial nerves are involved? It can result in dysphagia. Okay, dysphagia. Why? Because all these 9, 10 and 12 cranial nerves are very much important for swallowing. Okay, so the patient will have severe pain over the ear, and not just the ear, it is the whole of temporal area. The patient will be having pain, and along with that the patient will be having multiple cranial nerve palsy, and it is of course the facial nerve that is most commonly involved, because the stylomastid foramen is the nearest foramen near to the external canal, and from there it can spread into the various foramina known as jugular foramina, hypoglossal foramina, all that. Okay, but yes, it is the facial nerve which is involved first. Now how will you diagnose this condition? No, I mean, what is the imaging modality for diagnosis, for confirmation of the diagnosis? It is technetium 99 scan that is being used for that. Okay, technetium 99 scan is being used for confirmation of diagnosis, and it detects the osteoclast activity. Okay, because the osteoclast activity is increased in the case of this skull base osteomyelitis. Okay, and before we take an HRCT temporal bone, if you are able to, if the patient is able to afford a technetium 99 scan, you will be able to have an early detection of the condition. Okay, but yes, technetium 99 scan is not available in most areas. Okay, it is seen only in major cities. That is the severe problem associated with this condition. So most of the time it is a clinical diagnosis, and you will have to start treatment with just taking HRCT temporal bone. And yes, in this condition the closest differential diagnosis is actually malignancy of external canal, or rather malignancy of temporal bone. Okay, and what is the most common malignancy of temporal bone? It is carcinoma of ear canal, and carcinoma of ear canal requires treatment in the form of excision. Okay, excision has to be done if it is early stage. If it is a late stage, you will need to do surgery followed by radiotherapy. And the predisposing factors for malignancy of ear canal are chronic otitis media causing chronic ear discharge trauma whenever you are trying to remove the discharge. Okay, that is one, and the second one is radiotherapy to that area. These two are the common conditions that can predispose to malignancy of temporal bone, and squamous cell carcinoma is the most common cause of the malignancy of it is actually the most common type of malignancy of external canal. Okay, so why did I tell about malignancy of this temporal bone right now? Because it is a closely differential diagnosis of malignant otitis externa, which is not at all a malignancy. It is actually an inflammatory condition, but it is a severe inflammatory condition. That is a problem, and it is associated with multiple cranial palsies, just like a malignancy. And of course, it will have granulation tissue within the floor of the external canal, again like malignancy. So one important investigation that has to be done in malignant otitis externa is biopsy from the granulation tissue. Now, why do you do a biopsy from granulation tissue? So that you can rule out malignancy of external canal. Okay, so what have we learned about malignant otitis externa? Yes, we learned about the Levinson criteria which is needed for diagnosing the condition, and we learned that the imaging requires technetium and scan, and for assessing the prognosis of the disease you have to do another scan. And what is that known as? It is the gallium scan. Okay, that is to assess the response to treatment. Okay, response to treatment can be checked using a gallium scan. Okay, but the problem is this gallium scan is also not available anywhere. So commonly what we do is we assess the ESR or CRP, and ESR and CRP will come down when the inflammatory activity comes down, and with that we will be able to see if the patient is improving or not. Okay, even MRI also can be taken, okay, for assessing better soft tissue involvement, especially in a patient with multiple cranial palsy with malignant otitis externa. But when you are asked for the exam, entrance exams, you have to remember specifically the technetium iodine scan and gallium scan, although most centers don't have this scan. Okay, so technetium iodine scan for diagnosis and gallium scan for prognosis. Okay, now this condition has to be treated with IV antibiotics again for 6 to 8 weeks minimum. Okay, 6 to 8 weeks minimum it will have to be taken, and these antibiotics, as I already told you, are the antibiotics that are to be directed against the pseudomonas. Okay, and even at discharge you will have to give ciprofloxacin, and ciprofloxacin has to be given at a higher dose of about 750 mg BD. Okay, 750 mg BD has to be given, and even tab rifampicin has also been given for malignant otitis externa, apart from the routinely used antibiotics that are needed for the pseudomonas like the ceftazidime and piperacillin tazobactam. Okay, and levofloxacin. Levofloxacin is very much active against pseudomonas. Okay, and apart from all that, even rifampicin can also be used for malignant otitis externa. Okay, so that's about malignant otitis externa, and that is the most severe form of otitis externa. Okay, now let's go to the most benign form of otitis externa, and it is in fact caused by a golden colored the bacteria. Okay, the bacteria has got gold in its name itself. Yes, what is that? From the picture we can deduce the name. Okay, what do you think is the name of the bacteria? Yes, it is Staphylococcus aureus, because Staphylococcus means similar to a bunch of grapes. Okay, Staphylo means grapes. Okay, so this Staphylococcus, it resembles a bunch of grapes, and it has got the name aureus. Aureus means gold. Okay, gold. And the Staphylococcus aureus is the thing which causes a furuncle or boil in the external aortic canal, isn't it? Furuncle or boil in the external aortic canal. And where is it seen? It is seen only in the lateral one-third of the external aortic canal. Why? Because it is the only area where hair follicles are seen. Okay, so this is what is known as localized otitis externa. Localized otitis externa is seen only in the lateral one-third of external aortic canal. Now in this condition, you have to give antibiotics against Staphylococcus aureus. Okay, Staphylococcus aureus. And apart from that, of course, you have to do ear packing. Just like I told for diffuse otitis externa, you will have to do ear packing. So we have learned that localized otitis externa is nothing but the furuncle of the external aortic canal, and hence it is restricted to the lateral one-third of the external aortic canal, and it is being caused by Staphylococcus aureus, which is the organism which usually causes furuncle, and hence antibiotics has to be directed against Staphylococcus aureus. And we know nowadays the Staphylococcus aureus that we encounter are usually penicillin is resistant, so it is usually amoxicillin plus clavulanate that is being given, or you can give a cloxacillin which is having activity against Staphylococcus aureus. Okay, amoxicillin plus clavulanate to encounter the penicillinase resistance of the Staphylococcus aureus can be given along with local antibiotics in the form of ear packing. Okay, so that's about the localized otitis externa. Now coming to the fungal otitis externa or otomycosis. Before going to that, let's just revise what we have learned about otitis externa. We have learned about the various forms of otitis externa. When referred to otitis externa, usually it means bacterial type of otitis externa. Okay, otomycosis is the fungal otitis externa, but when plainly referred as otitis externa, it usually means bacterial. And this otitis externa can be divided into diffuse, malignant, and the localized type. And this diffuse and malignant one is being caused by Pseudomonas aeruginosa and localized by Staph aureus. So that's about otitis externa, and now we'll be going to the fungal type of otitis externa known as the otomycosis. Okay, now the most common type of otomycosis is being caused by, yes, it is being caused by Aspergillus niger, and it causes the typical wet newspaper appearance. Okay, that's why this video. Okay, the wet newspaper appearance is being caused by the Aspergillus niger. It is actually black in color. Okay, niger means black, isn't it? So Aspergillus niger is the most common cause of otomycosis. Now, how will a patient with otomycosis present to you? With the patient will be having severe itching of the ear. Okay, more than pain, it will be the itching. Okay, pain will be there, and pain is usually caused when the patient is trying to itch the ear. Okay, with some feather or something. Okay, and so Aspergillus niger is the most common cause of otomycosis, and it causes the typical wet newspaper appearance. Okay, wet newspaper appearance. And the second most common cause is, yes, it is actually causing a curd-like appearance or woolen fluffy type of appearance, and that is nothing but candida. Okay, candida. So that's about otomycosis. Otomycosis, most common, it is being caused by Aspergillus niger, and second most common by candida, and third most common by Aspergillus flavus. Okay, these are the three different causes of otomycosis that you have to learn about. Now, how you treat otomycosis? You will have to do the ear toileting by suction clearance to remove the otomycotic debris. Okay, ear toileting is very important. And antifungal ear pack also can be kept, and local antifungal ear drops have to be given. Okay, local antifungal ear drops such as clotrimazole. Okay, clotrimazole ear drops can be given to treat the patient with otomycosis. Okay, and no systemic antifungal is given. Okay, that is one thing that you have to remember. No systemic antifungal is given for otomycosis. Okay, now otomycosis is also seen when a patient is having a wet ear. Okay, that is in a patient with chronic otitis media, there is high chance of having a otomycosis. And apart from that, when you are bathing or when you are swimming, if the water enters your ear, there is high chance of getting otomycosis. Okay, these are the predisposing factors for otomycosis.